Good afternoon, everyone, and welcome to this afternoon's Innovation Theater. My name is Oscar Guzman. I am the Vice President of Medical Affairs at T2 Biosystems. And today I'd like to welcome Dr. Kaylee Caniff. Dr. Caniff is a pharmacist scientist with specialized clinical training and expertise in infectious disease pharmacotherapy. She is currently a postdoctoral research fellow at Wayne State University in Detroit, Michigan, in the US, where she focuses on investigating health outcomes associated with drug-resistant infections. We are looking forward to our presentation today, and I ask for your undivided attention. Thank you.
Thank you so much for that introduction, Oscar. So today I'm going to be talking about a project that I'm working on entitled Opening the Door to Candidemia Diagnostics, a desirability of outcome ranking analysis of T2 Candida versus blood culture in critically ill patients. So today I'm going to discuss the limitations of conventional outcome analyses of laboratory diagnostic strategies in patients with candidemia. I'm then going to apply a desirability of outcome ranking analysis to compare outcomes among critically ill patients diagnosed with candidemia by T2 Candida panel versus blood culture. And finally, I'm going to assess the overall clinical benefits that are associated with the use of T2 Candida in candidemia management. So the focus of my talk today is candidemia. So this is a significant problem. It's the fourth most common nosocomial bloodstream infection, and its highest incidence is within the ICU. The ICU is a known risk factor for the development of candidemia. Now, 90% of cases are caused by 5 different species, and they are Candida albicans, glabrata, tropicalis, parapsilosis, and krusei. So again, we know candidemia is quite burdensome within the intensive care unit, and this is an environment that really sets up the perfect storm for the development of candidemia due to immunosuppressive factors, the breakdown of immunosuppressive barriers, as well as widespread use of broad-spectrum antimicrobials. So the mortality rate is quite high in candidemia. It's 20 to 40%, and candidemia is associated with an increased length of stay in the intensive care unit, on average of 13 days, and also increased costs of care. So on average, it increased costs by $8,000 US. So blood cultures are the traditional tool that we use to diagnose candidemia. However, they have numerous shortcomings. Specifically, they have poor sensitivity. So we know from autopsy studies that they're only 50% sensitive for Candida. And furthermore, if they do become positive, there's also often a delay in positivity. So they take 2 to 3 days to turn positive. Well, why is this a problem? Well, we know that a delay in therapy initiation is associated with poor outcomes. In this study here, the authors looked at the association with the days to start of fluconazole compared to mortality, the frequency there on the y-axis. So as you can see, if therapy was started on the culture day, mortality rate was around 15%, but this increased by day. So if therapy was delayed to day 3 or later, mortality escalated to over 40%. So I mentioned that blood cultures are a poor diagnostic tool. Now we have a new tool available to us called the T2 Candida panel. Now this is a rapid diagnostic platform that uses T2MR technology, which is like a miniaturized MRI technology. And it detects the 5 most common Candida species and grouped results. Now there are several advantages to using the T2 Candida panel in practice. It has over 90% sensitivity and specificity. It utilizes a whole blood sample that requires minimal processing. It's also culture independent, so the patient does not have to have a positive blood culture to run this test. And its results come back very quick. So within 3 to 5 hours, you will know if the patient is positive for a Candida species in their blood. So we know that T2 Candida has the potential to reduce time to therapy when you receive the results within 3 to 5 hours. So in theory, we can initiate targeted therapy faster. And we know that there's a potential mortality benefit with initiating therapy earlier in the disease course. So this begs the clinical question, can using the T2 Candida panel in practice in critically ill patients improve mortality rates in this setting? So my colleagues and I at Wayne State decided to conduct a real-world multi-center evaluation of the T2 Candida panel compared to traditional blood cultures. This was a multi-center retrospective study. We included 14 US hospitals that were matched by various characteristics. And we targeted enrolling 500 patient cases. Again, comparing the T2 Candida panel versus diagnosis by blood culture for the primary outcome of 30-day all-cause mortality. So the statistical methods that we used, we described the data with frequency and mean or median. We also used comparative analyses. And then finally, as I'll get into later in this presentation, we applied a desirability of outcome ranking analysis, and we adjusted for confounders using inverse probability treatment weighting. So to be included in this study, patients had to be adults, diagnosed with candidemia by blood culture or T2 Candida panel, and then admitted to the intensive care units within 72 hours of that positive result. We excluded vulnerable populations. We also excluded patients who died or were transitioned to hospice care within 48 hours, those who were COVID-19 positive, or those with a bacterial bloodstream co-infection. So once we reached around 300 cases, we decided to conduct an interim analysis to check our progress. We looked at baseline demographics, illness characteristics, treatment characteristics, and clinical outcomes. So the next slides I'll walk you through is the results of that analysis. So here are the baseline demographics. So as you can see, the mean age was around 60 years. It was 54% male. And we do have some differences in the groups looking at the various racial demographics. In terms of illness severity, we are seeing a trend towards a higher Apache 2 score in the blood culture group, although not reaching significance. However, there was no difference in Charleston Comorbidity Index or having an immunosuppressive factor. In terms of management, so we're seeing a difference here in terms of infectious diseases consults. So patients with the T2 Candida panel were more likely to have an infectious disease service consult. However, in terms of other diagnostic procedures like echocardiogram and eye exam, there was no significant difference. So now moving on to time to antifungal therapy initiation. So as you can see here, we have hours to first therapy initiation on the y-axis. We have our study groups on the x-axis. So on average, patients with the T2 Candida panel were being initiated on antifungal therapy within 5 hours versus blood culture. They were not started on therapy until around 42 hours, and this was significantly different. However, this did not translate to a mortality benefit. In both groups, the mortality was around 36 to 37%. So although this study is not yet powered, there were no trends, again, in mortality benefit observed with the use of the T2 Candida panel, despite having a much faster initiation of treatment. So why are there no differences in mortality? So we think there's a couple different factors at play. First, we think that the patient population in this study may be more complex than the initial study that I introduced in the early part of this presentation. So patients have higher frequency of organ transplant, they're receiving more immunosuppressive medications, so overall they're more complex. We also know that echinocandins are now first line in this setting, and at the time of the publication of that first study, fluconazole was considered first line. So there may be some potential survival benefit with the widespread use of echinocandins. So overall, we think that 30-day mortality may not be the best outcome that's reflective of T2 Candida's potential benefit. So we wanted to look at this data a little bit differently. So we decided to look into conducting a desirability of outcome ranking analysis, or DOR analysis. So what is this? This is a novel method for analyzing data. It was first created by the Antibacterial Resistance Leadership Group in 2015. And in this outcome, patients are classified to their overall clinical outcome, which accounts for benefits and harms simultaneously. To date, there have been over 12 clinical trials that have utilized a DOR outcome analyses, and this continues to grow. So to give you a better idea of what the DOR analysis is, so the primary outcome utilizes a DOR scale. So this combines outcomes on an ordinal scale, and patients are assigned a scale ranking, a mutually exclusive ranking, according to their overall outcome. So looking at this picture here, you can see this DOR has 5 different levels. So a patient can receive a score from 1 to 5. 1 means the patient had the best possible outcome, so they were alive without any adverse events occurring. If the patient were to receive a score of 2 to 4, they were alive, but they had 1 or more adverse events occurring during the study period. And then finally, the worst outcome is death at a score of 5. So all of the patients are ranked, and they are provided a score, and then we compare the distribution of rankings between the two groups. Our final result is the better DOR probability. So this is the probability that if you were to randomly select a patient from your intervention group, do they have a better outcome compared to that control group? So if the interventions are equal, the better door probability will be around 50%. If the intervention is better, it will have a better door probability of greater than 50%, meaning that patient has a higher chance of having a better outcome if they were in that intervention group. So again, to give you a comparison of conventional analyses versus door analyses. So conventional analyses traditionally analyze efficacy and safety outcomes separately. So you don't know which patients are experiencing the benefit and the harm simultaneously. Versus a door analysis, you're looking at multiple efficacy and safety endpoints at the same time. So conventional analyses overall don't give you the overall clinical and safety impact on each patient. However, with a door analysis, you're really able to see, is this treatment strategy globally better? So we decided to pilot a door analysis in this study with a subgroup. We specifically looked at 2 of our sites that were included in the study. So our blood culture site is the Detroit Medical Center, and our T2 Candida site is Henry Ford Health. Both of these sites are located within Detroit, Michigan, USA, and serve an urban population. These sites were selected due to our access to the medical records. There were some additional outcomes we wanted to look at. And it also really removes variation in T2 Candida use, because what we were finding is that each site was utilizing this test differently. So in terms of these 2 sites, so they are both large hospital systems. So the DMC included patients from 4 different hospitals. Henry Ford included patients from 5 different hospitals. Both of these health systems have level 1 trauma, academic affiliation, and then importantly, looking at the ICU antifungal policy, the Detroit Medical Center does not have a policy in place in regards to drawing blood cultures or starting antifungal therapy. It's really at the discretion of the provider. Whereas at Henry Ford Health, there's a specific policy in place where antifungal therapy is initiated in addition to obtaining a T2 test when there's clinical deterioration or worsening after at least 72 hours on broad-spectrum antimicrobials. So DOR has not previously been utilized in this setting, so we had to create ours from scratch. So the first thing that we did is we conducted a literature review utilizing DOR methodologies. We then consulted with ARLG team members. And finally, we refined our DOR outcome with our study team members and Candidemia experts. So this was the final DOR scale that we came up with. So as you can see, there's 4 levels here. So the best possible outcome is being alive at 30 days without any deleterious events. And then levels 2 and 3, the patient was alive at 30 days, but had 1 or more deleterious events occur. And then finally, the 4th level was death at 30 days. So our deleterious events comprised of either an infectious complication or treatment failure defined here. So this is the baseline demographics of this subgroup to which the DOR analysis was applied. So overall, these patients were 62 years old, 53% male. Again, we're also seeing some racial and ethnicity differences between the 2 groups. We're also seeing a difference in illness severity. So patients at the Detroit Medical Center, the blood culture site, had a higher Apache 2 score, although there was no difference in comorbidity burden or immunosuppressive conditions. We were also seeing some differences in the organism breakdown by site. So at the Detroit Medical Center, there was lower Candida albicans and higher Candida krusei or glabrata. In terms of infection management, overall, these patients were being managed relatively similar, aside from having diagnosis by blood culture or T2 Candida. Almost all of them had an ID consult, and they were all receiving these standard management procedures at a similar rate. So moving on to therapy in these patients. So again, we're seeing that hours to first therapy is significantly lower in the T2 group. So these patients were receiving therapy at a median of 3 hours after the T2 Candida draw, versus at the DMC, they were receiving therapy at a median of 43 hours from blood culture draw. So here are the clinical outcomes for these 2 groups. So starting with infectious complications. So we're seeing some differences in the occurrence of infectious complications. Almost 50% of patients at the Detroit Medical Center or that blood culture group were experiencing an infectious complication. There were around 13% at the Detroit Medical Center that experienced treatment failure versus 4% at our T2 Candida site. And again, we're not seeing any differences in 30-day mortality. So this is the breakdown of the different door levels. So this is the distribution by study group. So on the top, we have T2 Canada or Henry Ford, and you can see 52% of patients were alive at 30 days without having an adverse event occurring. 15% were alive with one adverse event, and 33% again met that mortality outcome. And then on the bottom, we have DMC or a blood culture group. So 31% of these patients were alive without an adverse event at 30 days. 28% experienced one adverse event. 4% experienced two adverse events, and death occurred in 37% of these patients. So overall, when doing the door analysis, we found that the probability of having a better outcome if assigned to T2 Canada was 58%. So as I mentioned, there were some differences in some of the baseline demographics. So our next step was to apply an inverse probability treatment weighting. So this accounted for some of those differences. And again, we're still seeing that there is an advantage to being in the T2 Canada group. So in conclusion, the door analysis allowed for a more nuanced and global assessment of patient outcomes when evaluating T2 Canada versus blood culture. The use of T2 Canada, again, within an antifungal policy, was associated with an overall better outcome. There are some limitations. We did not look at cases that had a negative T2 Canada test or a negative blood culture, and this was exploratory. So our next steps would be to validate this with a larger population, and additionally, we want to identify how we can optimally use T2 Canada in practice. I'd like to thank all of my co-investigators and collaborators. And I will now take any questions. Yes.
Muriel Cornet from France. Maybe I haven't seen exactly the data, but the patient in the T2 group were treated with echinocandin more often than the others. So
Yes. So these patients in our door analysis subgroup, so patients at Henry Ford Health, they were received echinocandin as empiric therapy up front, and that was part of their antifungal policy that they have in place there. So yes, I think it's important to view the results of this within that context. So this was used within an antifungal policy and not alone, so there were differences in empiric treatment. However, using the T2 Canada panel in this way potentially could allow for de-escalation from that antifungal agent more quickly. So you can start the therapy and then hopefully get the results back within 3 to 5 hours and potentially then discontinue it if the results are negative.
But it may explain the better outcome also.
Absolutely, but I think it's important to keep in mind that if you were to start an echinocandin therapy in these blood culture patients, you're going to have to wait several days to be able to pull that off to know whether or not there is Candida present, if it even grows within the blood culture.
Thank you.
Mm-hmm.
So you had a significant difference in the Candida species distribution. Have you corrected for that? So compared door classification within only Candida albicans, or?
Yes, so that was one of the factors that went into the inverse probability treatment weighting. We did account for the species difference.
And another question, what adverse events did you put into this door classification? Is it more antibiotic side effects, or is it general complications of the infection itself?
Yes, so we primarily focused on infectious complications. So things like having a metastatic site of infection that wasn't initially present, having persistent candidemia, being readmitted, a readmission related to that index infection.
Thanks.
Thank you once again, Dr. Kaniff, for this great presentation, and thank you to the collaborators from both centers and all of the investigators. If you want any more information on our panel, the T2 Candida panel, or any of the other panels, T2 bacteria or T2 resistance, we are at D48. Thank you, everyone. Have a great afternoon.